Good afternoon. That sounded like an amazing person, not like me. Can I get a feel in the room, please, for who's a student? Faculty? Ring in, just interested? Okay. Thank you very much. Okay, majority students. That's useful. Hello again. My name is Pascale Allotey. I'm from the United Nations University International Institute for Global Health. Now, I'm pretty certain most of you would not have heard of UNU because it's one of the major I've been with UNU now for just under 2 years, and one of my major tasks is actually trying to promote it. It's actually been around for 40 plus years. It's almost as old as the UN. The university is almost as old as the university, as the UN, because it was set up to support the UN. The United Nations University was set up to support the UN. Global health has only been around for 12 years, but still should be better known than it is. I won't talk about that, but if you're interested, I'm happy to have a conversation afterwards about what the United Nations University does and what we do specifically within global health. Okay? So I'm, as Sophia says, I wouldn't say much more than that, but what I will add to that is that I'm from Ghana originally. I was actually born in Morocco. From Ghana, traveled a lot with my family as a child and as an adolescent, as a teenager. And so in some ways, it feels kind of natural having the global perspective because I've lived in several countries and I have a real sense of, and I've always been really interested in culture and understanding context and so on. So this is the lens that I bring to the work that I do. So when Sophia asked me to do this presentation, I tried to think about how to bring a little bit of work that I've done over the years. Sorry, can everybody hear me? Okay, and everybody understand me? Apparently I have a horrible accent. That's what the Malaysians say anyway. Okay, so I tried to kind of encapsulate a little bit of stuff that I've been doing, but actually what I want to throw out is something that is a particular passion of mine, which is about complexity and how complex the work is that we're doing and how much we lose out in simplifying it. So I checked, I just did a quick Google search on complexity and the general ideas. And apparently, Einstein says any intelligent fool can make things bigger and more complex. And it takes a touch of genius and a lot of courage to actually go in the in the opposite direction. So I'm a self-confessed fool in this context. And then on the flip side to that, I think the main message that I want you to take away is that enforcing simplicity, we actually lose the complexity, and we do ourselves a disservice by doing that. So essentially, it's losing the forest for the trees. So I'll go for I think I put this specifically for the sake of the students, but I think it's useful to actually think about it in this way. When we're conceptualizing a research project, we start from what the big idea is. And then we go from, no, you can't change the whole world, to find and define very specifically what is your research question. And then from that, we say, okay, if this is what you're interested in, how do you operationalize it very specifically into those research objectives that will allow you to choose the right method to be able to do the work? So we go from the big and try to crystallize that down into bite-sized chunks for the purposes of research. We decide on the methods, we collect the data, we analyze and interpret the findings. And if you're in global health, you probably have supervisors that say, what's the policy implications? How is this going to be translated? Standard 101. And then if you're doing a thesis that you want to assess, you need to then relate back your interpretation to what your question is, so that it is a complete, full story that loops back. What I want to push is that we often then don't go back to the bigger idea. So we end up crystallizing it down. We say what is relevant to the particular question that we started with, but we don't often then think back to, so what does this mean for the bigger world that we started off with? And then within global health, if you want your research to move forward, best case is that it ends up as part of the evidence that is drawn into the guidelines, the clinical guidelines or whatever guidelines that are actually then used to change policy to inform the work that is done. So there's within the World Health Organization, for instance, there's a guidelines development process. If you've written up your research well, it makes it into the band of high quality that is relevant and that is considered in making those broader guidelines. So being very specific, for instance, within that, there have been a range of studies, for instance, in when is best to, what the best interventions might be to prevent mother-to-child transmission mother-to-child transmission when the mother is HIV positive. And a whole lot of data has gone into that. And there is a very clear guideline, and I just took this off the website, a scheduled cesarean section to prevent mother-to-child transmission of HIV is recommended for women with high or unknown viral loads near the time of delivery. The C-section is scheduled for the 38th week of pregnancy, 2 weeks before the woman's date. This is best clinical practice to prevent mother-to-child transmission. However, this guideline has created a lot of problems within a whole range of HIV-positive communities because you have, there is no clarity there. If, for instance, you have a health system that is not adequately equipped to undertake cesarean sections, so what do you do when it's not a very clear, linear issue? There is nothing in that guideline that tells a clinician how to manage context. What do you do when the mother is anemic? Do you still do a cesarean section? What do you do in places where there are cultural taboos associated with cesarean sections, and therefore a cesarean section is a significant deterrent and you'll have mothers not even going in, even if they do need it. So there's some of these, there is a very linear way in which we move from evidence to policy that is actually not particularly helpful. And so, in some ways, it's easier, or the development of guidelines in that particular example is easier when you're talking about clinical cases or specific diseases. Within global health, when you then move into the much more complex areas that have to do with the human rights issues, with the social determinants of health and so on, it becomes even harder to crystallize what the issue is down to the point of your bite-sized research that will have the outcomes that you want and so on. So then moving from that as well, and then thinking about what the complex issues are, add another area of complication to it, which brings me to the main content and focus of this presentation, which is around gender. And we're celebrating some major milestones in progress or otherwise on gender, with a significant push from the UN Secretary General for agencies to deliver on gender equality. So we took on, within UNUIIGH, we've taken on a very specific mandate to explore exactly what that means. It's easy enough to say mainstream gender, gender equality, this is what everybody has to do, but what exactly does that mean? When a district officer comes to you and says, we have to see, you have to mainstream gender, what are you telling him or her to do specifically? So this is the big agenda that we've taken on. And it is meant to go beyond just the rhetoric of ticking a box to say, I've got a, we've got a gender focal point on the team, or we've got gender mainstreaming all across our documentation, so we're doing it. What exactly does it mean to do this? So we held a meeting in Malaysia, and this image is of most of what we were able to do was to bring together all the senior people within the UN, all the UN agencies that are responsible, so the gender focal points or the gender specialists across the UN, and mainly within WHO in particular, because our mandate is in health, with the WHO regional office focal points, gender focal points as well. Now, the interesting thing, and it was while we were focusing on health, and therefore we picked the agencies, the UN agencies that do health. So while it's WHO has the mandate, UNICEF does health-related projects, UNFPA, and so on. The global burden of disease is your starting point. So you're looking at what is killing people. So that's, and it's very much a disease focus. You're looking at men's health, women's health, and prioritization on the basis of your DALYs and on the basis of your life expectancy and so on. And for those who focused on health to achieve gender equality, what you then ended up with was this whole argument about why are we focusing on women? Because if you look at the global burden of disease figures, suicides are higher than this, and then you ended up with this competition about there shouldn't be a focus on women because actually men die younger. And so then if your outcome for your gender equality is a health outcome, the approach that you take to the work and how you think about it is quite different. So gender equality for better health, the arguments ran on the basis of gender power dynamics. So we're not necessarily looking at health as an outcome, but we're looking specifically at what we talk about socially, politically, and so on, what the gender issues are. These are the arguments that favor the patriarchal, not favor but based on the patriarchal society. Also, all of the discussions around feminism, social justice that are often controversial. But again, within this workshop, working it through with women, with the gender focal points, there was a problem with what the measurable outcomes are. So if you're focusing solely on what's the power, how do we change the power dynamics, how do you know that you've got it at the end of it, given it is actually a societal change that we're looking at. And then gender equality as the outcome, which is the UN Women's focus, means that there was a very much an argument around parity. So do you have enough women in leadership? Is it equal numbers at different, and then there's discussions around the gender pay gap and so on. So you can see the just for this SDG, and is the mantra that we all keep screaming about, we don't necessarily, we know at some level that we want the same thing, but because of the politics and so on of the competition of the individual agencies' mandates and so on, we still couldn't at that meeting, where we're all supposed to be delivering on gender, wasn't clear where it is we wanted to go and how it was we wanted to get there. So essentially, how do we work with this? It's definitely not a simple message, and it's still, at the end of it, it was, okay, so if we wanted to draw out a research agenda on the basis of all of this complexity, and at the end of it, I wanted my very simple outcome, in terms of simplifying it, was I needed to know if the Minister of Health from Ghana came to me and said he wanted to report on gender equality for universal health coverage, or a district health officer needed to respond to 3 different things. He was told, and these were actual examples, that he had to respond in his new annual report for 2019. He'd been asked to respond to how he was delivering on universal health coverage, on disaster risk reduction, and gender equality. Are these totally 3 separate things that he is supposed to be working on, or is there some way of actually making this a single agenda about health? And so then the questions are, how do we work in ways that can make this complexity real to people? How do we communicate these complex issues? Because it's important without making it impossible for the consumers of our efforts to work with. Now, I don't have any answers for this. But what I do have, and what I'm going to do is just give you two, I think within the time I can give you 2 case studies that provide some concrete opportunities to illustrate how I think we should be working, or we should be working more and more within global health in those next steps. I think we know what we do, how to do the research, we know how to do, presumably, the policy translation for that, but then, and so what? And that's the bit that I really want to focus on here. So the first is work that I did in northern Ghana. It's the northernmost part of, how many people have been to Ghana? Oh, a few. Up north? No? Okay. So it's incredibly geographically different. It is, as you move further north, you're moving towards the Sahel area, so you lose the greenness and the forest, go from the beaches to the greenness of the forest through to what is beginning to be the Sahel belt. Now, it's generally a very dry area, but in the interest of development, a dam was put in to dam the Volta and provide electricity to the rest of the country. What that has done is it's totally changed the ecology of the area. It is a really bizarre pocket if you look at the geographical mapping of disease, where there are a whole lot of tropical conditions that only actually occur in the wetter regions of Ghana. But the dam has totally changed it, and so there's much higher rates of onchocerciasis, filariasis, all the kind of mosquito-borne diseases that occur because of the damming of the area. So that's one bit of complexity to bear in mind. This is what the area generally looks like in places that are away from the water, the dammed area. And it is, the compounds are very spaced out, but it's still very much a sense of a community, but people communicate in different ways. So for instance, an example, when I was organizing focus groups, I had to, the way messages are communicated, now it's different because people have mobile phones, but at the time what we did was you'd stand on the roof and you'd shout out the message, the next compound would hear it and they'd shout out the message. So I had no control over the number of people who turned up for the focus groups. But it worked. I mean, that was the way the community worked. It was either that way or through at the markets on the 2 days of market days. Within an individual compound, the structures were built in different ways, and the nature of the structure said something about what that building is. So a bedroom was in a particular way, the kitchen was built in a particular way, and so on. Polygamous community, so men could take up to 4 wives, some more, but it was generally the average was that men had 4 wives, and each wife was in a different building. The critical thing about the 4 wives is that there was a hierarchy, and it wasn't necessarily whether it was the first wife, second wife, third wife. It also had to do with the wife's family. So there was a whole family dynamic within that, and the gender dynamic within that, and the relationship between the wives, whether they were younger or older, what the status was between them, and so on. Again, relevant because it had major implications for decision-making about who was or wasn't allowed to go to the health services. And the research that I was doing was looking at the barriers to the use of, well, it was actually about the implementation of the WHO guidelines, which is why I gave the guidelines story in the beginning, the WHO guidelines on antenatal care, which at the time was you need to have at least 4 antenatal visits for screening to ensure that you could identify the high-risk pregnancies and therefore provide different management for them at the time. So that was supposed to be a simple, quite a simple question, drawn down. But in fact, what I ended up doing and what got me really passionate about mixed methods at the time was that I had to be able to look at what was happening in the antenatal care. The Ministry of Health had me running the antenatal clinics out of the district hospital. For the women who did not come to the hospital, I ended up working with them in the community, but also with the herbalists and soothsayers and other traditional healers who worked with pregnant women. And because of the tropical diseases and the culture within the area, the medical system was, the traditional medical system was based totally on the explanation for a particular disease. So with lymphatic filariasis, those who had swollen legs, you went to the traditional healer who did stuff around legs. So it's the same person who would put a splint a fracture, for instance, was also the person who would look after you if you had filariasis of your legs. If it was filariasis of the arms or of the testes, you went to a different type of healer because it was the medical system explained that condition in a different way. So it was a really, for me, it was an amazing opportunity to really embed myself within the community and do a really rich ethnography about the medical systems, and therefore how one even began to think about merging and trying to get convince women that they had to go to the antenatal clinic when it was a totally different belief system. It was a totally different dynamic about deciding how to go to the hospital or not. So, and as you see, this was, it's not a very clear image, but this is a ladder that was made. A lot of life happened on the rooftop. And people just climbed, and everything from sleeping to drying clothes and so on. This is, again, just another example. And within the compound, there were areas that the men weren't allowed to go. Women who gave birth in the compound had to give birth in areas where the cow dung was dried and created as a carpet. It was actually amazing to walk on when it wasn't smelly, because it created a really nice, soft, bouncy area. And that was where women would give birth. So within the household, they could, wander around when they were in labor. The study was designed so that one community had bed nets, one community didn't. And the outcomes that they were measuring, again, very simple, to see whether the bed nets were reduced malaria or not, was that they were looking at reduction in under 5 mortality. When you actually spoke to people in the community or observed what they did in the community, the men did not let the women sleep under the bed nets, because the bed nets were seen as a way of repelling the mosquitoes. It was obviously the men that needed to sleep so that they could go out and work. So they needed to be the ones that had a good night's sleep. And so you go to the community to find out what was happening. And the women and children did not sleep in the net. So in terms of a study design, it wasn't probably the best thing, the best way to look at it. Now, having said that, it was being there gave me the opportunity to feed that back to the researchers as well, so that then became a part of the intervention. And then the hospital bit, in running the clinics, you then went to the hospital, and it was running the antenatal clinics. It was very clear that the women were not treated well when they came there. They had to walk miles to get to the clinic. And you can see the box there, which is the cold box for the tetanus shots to maintain the cold chain. And the nurses would not start a vial until there was an optimal number of women there. So it didn't matter whether you came at 5 a.m. to be there first. Until there were 10 women or 15 women there as well, the clinic wouldn't start. So there were a whole range of issues there. Now that enrolled nurse, I remember, was telling the women that if they were going to come and give birth in the hospital, they needed to make sure that they brought their own rags to clean up after them, because she wasn't going to be doing it. So there was no incentive really if the woman faced resistance in her compound anyway to get to the antenatal clinic. When she got there, she wasn't treated properly, so there really was no incentive to actually undertake all of this. So then I won't take you through the whole story of the outcomes, but just as a way providing the context to say, how do you, within this complexity, what does it mean to adhere to the WHO guidelines on antenatal care? You've got the gender and societal norms and the impact on decision-making and access to resources. You've got infectious diseases, comorbidity introduced as a result of development. And I threw that one in because within the clinical system, the antenatal clinics did not address or deal with the infectious diseases. That had to be treated as a totally different thing, as if it was a split body. So the women had to go to the infectious diseases clinic to deal with any problems with, and schistosomiasis was probably the biggest problem with that one. And obviously malaria, the antenatal clinic took on, but everything else they had to present somewhere else. Disrespectful health services. And then the human resources research capacity and human dimensions of the health system. And I put this in because once the nurses were trained, there was no opportunity for any further training. So you can talk about an updating of clinical guidelines, and this is best practice, and this changes, and UNFPA says do it this way, WHO says do it this way, and there is no actual way of disseminating that as part of the health system beyond the fragmented individual projects or PhD students or whatever who would fly in and do their research and fly out. So it's a very, I mean, there's a huge complexity there. So just taking the guidelines and saying, well, what is the outcome of that and how should the policy change when you've got all of this noise in the background is complicated. And I will leave it there in order to go to the next case. Can I pause for a second and find out if there are any questions? Yes.
I'm just curious, like for that example, what's the outcome?
I'll come back to that. That would be a spoiler. Any? Yes.
Was there any use of drugs to stop the transmission of HIV from pregnant women to babies?
No, not at the time. Yeah, no. Okay, so a totally different case, and this focuses and I'm full disclosure, I am not a lawyer, so I may be totally bastardizing the information here, but this is based on work that we're doing now with the CSO, largely a CSO community in Malaysia. The civil society organizations in Malaysia. And any Malaysians? Do I have to give you a little bit of a background about Malaysia, or everybody knows? Yeah, just a little bit? Just a little bit, okay. So Malaysia is one of the more complex, it's a lovely country to visit. It's got the Twin Towers. It's described as Asia Light. It was a British colony, so there is a fair bit of English. You can get away with English, but the national language is Bahasa Melayu. And it is slightly different from the others because it is home to 3 or 4, depending on how you look at it, major ethnic groups. It's predominantly Malay, and Malay equals Muslim. The law makes it compulsory for, if you're ethnic Malay, you have to be Muslim. There is no question about it. If you can choose to convert out, but that's a whole process that involves being, you have to go back and be re-educated, because if you knew about Islam, you wouldn't want to convert out and so on. So it's just easier. It is by law, and the police will check. If they check and you're Malay and you're in a bar or doing anything that's haram, you will be subject to caning and all of that. So it is by law Muslim, and you have to practice if you're Malay. And then so it's the Malay community is about between 60 and 65%, but it is an Islamic country by the constitution. And then there's about 30% Chinese, and then the rest Indian. And it's historically, the British did their thing and brought different people from at different times during the colonial periods. And so there's a mix of these three major ethnic groups. There is a fourth, that is the Orang Asli, the indigenous people. But the Malaysian government, the Malay government, has absorbed the indigenous population, and together Malay and Orang Asli indigenous populations have been created. There's a new category, census category, called Bumiputra, which is Princes of the Earth, and that brings them together. Just as a quick side comment to that is that has to do, in some ways, if you take the cynical view, and I just remembered I was on camera, if you take the slightly cynical view, and this is in the public domain, so I can say it, it has to do with the around the time of the end of the MDGs, poorer health outcomes with the Orang Asli population. So bringing them together then kind of conceptually made sense. So then the outcomes then kind of looked a little bit better.
We can edit
so to speak.
anything else.
Yeah. Okay. So there is that dynamic happening. The Orang Asli really do remain or prefer to remain in the more rural, remote areas, and the previous government, the government changed almost 2 years ago, but the previous government, the policy was if they would provide development to the Orang Asli population, but they had to convert to Islam to be able to access it. So it is a very complex system. It's a federation of states, and law is made at both the national and state level, but it does have a dual justice system. It's got the codified law and it's got the Sharia law. There's some states that are absolutely Sharia, and they almost don't engage at all across. And according to this constitution, the federal law prevails over Sharia law. But there are reasons why, you know, if there are things that you question, you're either subject to blasphemy or you're subject to what's the word I'm looking for? When you say something that incites racial tension. No, not libel. It'll come to me. Yeah, you're not allowed to talk about race-related issues. So when I'm talking, when I report on the social determinants work, I just report it as it is. I can't interpret. Otherwise, I'm inciting racial division. Yeah. Okay, so that's an overview of the legal system. And I'm just going to go through very specifically the sexual and reproductive health and rights issues within that as it relates to the gender work that we're doing. Some of these are not relevant, some are. So within the federal penal code, there's the issues around consent, rape, and so on. That's fairly self-explanatory. The Sharia law regulates issues related to sex, sexuality, and marriage amongst Muslims, and it is supposed to be specifically amongst Muslims. Community where it is declared a Muslim state, and there is majority Malay. It is really difficult even if you're non-Muslim to access the courts otherwise. So in the Sharia states, you go to a supermarket, for instance, and men and women aren't supposed to stand in the same line. Men queue and to go to the checkout counter, you can't stand together. You can't sit together in theaters and so on. KL is not like that. If you visit, so please visit KL. It's awesome. But it is when you go to the more rural area. Well, it's not even rural. When you go to other states, it's a little bit different. Sexual intercourse out of wedlock. Anal sex, sex between females, posing as a woman, and indecent acts in public. The law on the age of marriage, mean age at first marriage, according to the last survey that was undertaken for women, and this is the official data. Okay, I'll come. I've got a summary. But between 2010 and 2015, there were, so there is a law about what the age is, but you can apply to the Sharia courts if you want your daughter to get married at a younger age. So there are always ways around it. Many young people and parents cited marriage as a common method to fix the problem of unwed pregnancies, as most of them genuinely believe that marriage was the best option to secure a girl's future, and that it was in their best interest. So this is based on research. In addition to compiling the regulations, we also then did some focus groups to find out how it was being implemented. Access to contraception, again, an important one. Regulated normally under the Poisons Act, and within Sharia law, contraception is used to limit the number. Contraception used to limit the number of offspring is forbidden, and it is permissible under one of the following conditions. As in, contraception is permissible if the wife is too weak or too ill, if there's a hereditary disease, or to space the pregnancies for reasons of health. But this is data that has been compiled recently towards ICPD. So this is a report that was done by ARROW, one of the regional organizations, and this across the region. And the Malaysia data suggests that the adolescent fertility is 11.5 per thousand. So from the Malaysian Ministry of Health's perspective, this is very good. They look better than the others in the region, so it's not a problem. Okay, low and underserved populations. It is, if you know anything about the kind of the politics of Malaysia, there have been under the previous government, the leader of the opposition was jailed because he supposedly had engaged in sodomy. The Sharia law provisions enacted in is enacted in almost all provinces, and it criminalizes male-to-male sexual conduct. Gender identity is also there are issues related to that. So there's no recognition of third sex or third gender status. There is a penal code that any act of gross indecency in public or private is a crime, and their cross-dressing obviously is not allowed, obviously. Now, last year we ran a health and human rights course that Sophia came to, and I don't know if you remember all the people in, yeah. But it was an amazing, really amazing few days that we spent, because we actually brought people from the various communities to have a dialogue around how they experience the issues. And it was, under the new government, it was actually allowed for us to engage publicly in these debates. Migrants and refugees, a major problem. I wouldn't talk about that in America. You probably know a bit more about this area than I do. And the government comes down really hard on access to sexual and reproductive health services for migrants and refugees. For women, domestic workers who come in, even if they come in legally, part of the contract that they sign with immigration says that they're not allowed to have sex And if you get pregnant, obviously you've disobeyed the law. There are immigration centers that are put at the hospitals. And so the women come out of postnatal care and they go straight into detention and get sent away. Okay, so again, going back to implementing guidance about very clear things, and we tend to be very good about what it is we should or shouldn't be done in terms of the recommendations. Sexual orientation and gender identity rights should be recognized. This was the big report that was done. Duh. But what does that mean when you have to work within this sort of context? Rights of non-citizens have to be recognized. Awareness and training of health staff has to be done. So understanding the problem is not enough to find the solution, okay? So moving beyond it. So this is so what we need to do, addressing the gentleman's comments from the back, that providing the straight policy direction that is based on the evidence that we know may be based on the evidence that we know, but is not enough. And if we look at the way a whole range of other disciplines and other industries work, they're a bit more nuanced than that. I mean, if we take it from whether it's from the business community, whether it's from the media, there are ways of actually forecasting, not predicting, but forecasting. And I think that what I'm trying to push within the Institute is that we become a bit more nuanced in how we produce this. So I've become interested in how one does this in a rigorous way, so that it's not just, anybody can pull a solution out of a hat, but how do you do it in a meaningful way? And there are actually, having looked at it, I actually found that the UN, my own institution, the United Nations University in 2006, was commissioned by UNDP to set up a whole lot of futures projects, and there is now a global, not now, I think since about 2008, there is the State of the World's Future report that comes out every year. And so I then went to look at the methodologies that are used for it, and it is essentially the argument that I'm making is that we need to future-proof the interpretation of the results and policy recommendations. So the question to that is, what difference in designing the research within that, what difference does it make? That is what we want. That is a question we want to focus on. What are the possible alternative solutions, and what difference will it be able to make? What is the future? If we start off with what is the future we want? What is the outcome that we're seeking? Because the research tells us what the problem is. How do we go beyond the simple linear to then actually designing other research that will provide us with some of these alternatives for which we can then test through different research methods, be really creative and innovative through different research methodologies. And I think there are further challenges in thinking about it as the future we want versus what is possible. So looking, very specifically, for instance, at doing financial economic simulation. So you can say if this were the intervention, this is what the intervention will cost, and this is what you hope the outcome to be. So this is the return you're expecting on your investment. If you didn't do it, what would the cost be? If you did it in a different way, or you considered a different part of the question, what would you do? And what that does is it gives you, when you make a policy recommendation, a set of alternatives that you can give to whoever you're providing the policy brief to. So that's the one of the major advantages to it. The other is that being able to pose those extra questions allows us to throw in a bit more of the complexity that we otherwise don't tend to look at. So it may be that with the antenatal clinic example that I gave in Ghana, with the range of different things that the range of different complexities within that, there is a policy decision that you come to, but then you interrogate that further and say, okay, so if something happened to that dam and the disease rates went up, how would that change this policy that you're doing, and so on. So it just provides an opportunity to, and there are, again, very specific methods around that. So there's systems thinking that allows you to do kind of feedback loops, and I can see Laura smiling there. That allows you to do a range of feedback loops in the provision of different policy options. There's scenarios or alternative futures. And if you are interested, I can give you, there are a range of references associated with this, and a whole, literally a tome that goes through them, and a range of simulations as well that one can go through. I had this as an example to actually talk about it, but I can see I have just 10 minutes, and I'd rather, yeah. So I'd rather take questions on this rather than keep going. But ultimately, this then goes back to the initial bit. It's not enough to just focus on the research question and reduce it down. We need to remember to take it back up. Remember that the trees are a part of a forest, and we need to make that link. Okay, thank you. Questions?
The floor is open.
Could you list those resources you were just talking about for systems thinking, simulations, that kind of thing?
The systems thinking is actually, you can just literally type that in Google and it comes out. It's a book that was put out by WHO. It's Systems Thinking for Health Systems, written by Don de Savigny. That will come up. But what I'll leave some links with Sophia to distribute to you as well. Type in the state of the world, the Millennium Project. That as well will give you where the state of the world's futures reports come out, and the methodologies that are associated with that.
I have a question.
Yes.
You know, at the state level, the strict Sharia law, how do you overcome that as a researcher? It just seems to me the honesty, sexual activity, you're a researcher, and it seems to me that I know in other parts of the world these laws are difficult to enforce. It's more to scare the people and keep the people in mind. So I'm just curious, when you work with them and for someone to give you that information, they're putting their life in the right way.
So we work a lot with the civil society organizations. We work with while I talked about the main courts, kind of the Sharia court and the federal court, there are a lot of decisions are actually made through local kind of extended family group arbitration and informal court system. And it's often easier to work through them, to work with them for them to come up with what they think some of the best solutions might be. What we absolutely want to do is to avoid having a case actually go to the Sharia court. Because once it's escalated that far, it's really hard to pull back. Yes. Yeah.
Do you find when you're in these communities, do you find that there are people who are receptive to what you're trying to the information you're trying to get about, and people who are stopping you?
Yes, it's in some ways it's because people know what the agenda is and so on. It's easy. There is no difficulty identifying the civil society organizations and individuals who will gravitate towards the UN system because they can they know they're protected in some way. I think one of and it's just really quite recently that I'm pushing my team for us to move outside of that. If we don't try and work with the hardest of the Sharia courts, if we don't try and work with the dissenters, we won't be able to, we will continue to work within a little silo. So if we say there's complexity, let's confront it and let's learn. So it is as I say, this is very much about learning, but it is for us to learn those strategies that allow us to move outside of the zone that we already know buys what we have to sell. Yeah. Oh, sorry, I had one here and then.
I guess this kind of is opposite of what you're talking about, but I'm curious what you see your role like in the future. Are you trying to like reform? Because it seems like a lot of the principles you're talking are fundamentally compatible with the cultural context
To disrupt.
Yeah.
Yes, absolutely. Yeah, yeah. And I think one of the really nice things is that, again, within Malaysia in particular, with the change of government, there is a bit more openness to actually engage with some of the ideas. And once we had that crack in the wall, we're trying to hit the wedge in and open things up a bit. But more globally, it is, I think, if we begin to, all of us within global health, begin to engage much more in not ending the research at the, this is what I was planning to do, I've done it, here it is, and just say we have to make a difference. We can't focus on those individual outcomes and then have somebody else have another agenda on, I don't know, climate change or all of these other things that are today's priorities. Compete. How do we work with them so that it's not a competition and it is rather being able to build on and extend the advantage that we can get. Yes.
Yeah, from Malaysia with Sharia law.
Yeah.
Let's go back to Ghana.
Yeah.
In the last 20 plus years, Ghana has seen an uptick in Christian sex, and particularly Pentecostal. Are you getting pushback from those areas and what you're trying to do?
Yeah, absolutely. I think I just used Malaysia as an example, but I think the issue is not, and I'm very carefully, the issue, I didn't say problem, the issue is not Islam, the issue is fundamentalism. And it is, that is the major pushback, and that's happening both across almost all religions. Yeah, absolutely. Yeah.
I'm just wondering, you mentioned like in advertising work, you guys will come up with what you find the solution to that?
So the offshoot of that is that there is now a program that is about involving men and involving the community leaders as part of pushing and getting women, getting the husbands to give women, their wives, permission to move out, to go to the antenatal clinics. But it has.
You mentioned, for example, getting quality treatment at the health center.
Yeah.
Is something which is
Yeah.
not really good together.
Yeah.
So,
Yeah.
is there a way of like an incentive for this to like actually?
It is this notion of complexity that it's not a single solution. So yes, I mean within most health systems now, over the last, I presume UHC, but probably for some areas predates that, there is a real push for quality care as well. But these are, and this is the point that I'm making, that each of these is a separate, I mean, within WHO, from one office to the next, they're each focused on what they're doing, and there are very few opportunities that they get as an institution to actually come together and say, okay, what you're saying is exactly what we're saying. How do we combine all of these efforts towards something? And there is, within the guidelines development group, there's now a push to integrate the best practice, so that it's not just a single thing, but if it's about antenatal care, what does the health systems guidelines say that intersect with that, so that they're consolidated guidelines produced that try and bring those together. So it's happening.
So time is really is pressed. If I can just take the last two questions and then you can hear them and then respond to them, and then
Okay.
we'll close if that's okay, please.
Next line is one. You've laid out quite a bit of methodology and research problem solving. I was wondering if, in your opinion, there's the U.S. agency or NGO that implements this well that we can sort of look at as an example.
UNDP does it. Oh, sorry. Yeah. I'll take the second one. Yeah.
You mentioned return on investment methodologies. I was just curious what kinds of methodologies are being used. Is it traditional cost-benefit analysis? Is it social return on investment analysis, or other frameworks?
All of the above. Yeah. And it is the preparedness to say, okay, I know that there's some ways of engaging with these ideas. This is not my expertise, but opening your mind up to say, okay, let's bring people in to brainstorm about how do we present this in different ways. And yes, UNDP is probably the lead agency that is actually working in this space. Yeah. Very specific cases?
Yeah, sort of like the virus.
A gazillion. There is actually, so UNDP has a training center in Singapore that does futures methodologies. Yeah.
And so with that, can you all join me in thanking Pascale?